Just a quick heads up before we begin. Everything in this episode was accurate when we recorded it, but things move fast in evidence-based medicine. For the most up-to-date and definitive information, then please refer to Red Whale Knowledge. And if you notice anything that might need updating or have any feedback, then we'd love to hear from you. Now, let's get started.
Hello, I'm Fiona Ritchie.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care because we're here to make your life easier.
Welcome to the Football Has Come Home. Congratulations to the Lionesses, Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
So grab your preferred drink of choice with ice, your trainers, sunnies or your dog lead. And here's what's bubbling up as we dive in search of our pearls for this month. Here's what's bubbling up this week. Women on skinny jabs must use effective contraception, the MHRA urges in its latest guidance. Now, those were the words of the government press release published on the 5th of June 2025. So what better time to share our newly updated article on contraception and weight, which includes this MHRA guidance. Keep listening to learn more about considerations that we need to make in supporting people living with obesity or struggling with weight issues, focusing on choosing contraception, accessing emergency contraception, and planning contraception or pregnancy if they're taking GLP-1 medication or have had bariatric surgery.
There is no safe level of drinking. Have we missed the message? The 10-year plan is out. There are many questions about delivery, but few doubt the vision and need for a health service that endeavours to seek prevention over sickness. But up to 1/4 of the UK population drink alcohol in a way that is potentially or actually harmful. And this disproportionately impacts men and few access treatment. It's recently been Alcohol Awareness Week, so our Pearl considers how we can use the audit tool to identify potential alcohol use disorder, how we can deliver brief intervention, because it works, resulting in 1 in 8 reducing their alcohol consumption. So how can we do it? Well, we share with you the FRAMES model.
I'm bubbling under for next week. It's getting hot in here. At this time of year, on those hot afternoons in our consulting rooms, hands up if you think it can feel a bit, well, sweaty. Or perhaps don't put your hands up. Do you remember the antiperspirant advertising campaign from the late 80s, which was frankly sweat shaming? For people with hyperhidrosis, sweating is a year-round challenge that significantly impacts quality of life, relationships and work. Hyperhidrosis is thought to be underreported, possibly because people feel embarrassed. So how should we approach the consultation if people do raise concerns?
It's recently been the WHO World Hepatitis Day, so we thought we would reshare our article on hepatitis C, which is a popular and impactful topic over the past 18 months on our update courses. We're doing this because more than 95% of people with hepatitis C can now be cured with a single course of safe, well-tolerated treatment. The WHO has set a global target to eliminate it by 2030. The UK is ahead of schedule, with England aiming to achieve elimination this year. That's 2025. We're going to zoom in on who we should test and how we should interpret the results.
So whether it's doing your action plan with your gran,
Your action log with your dog,
or shouting, "I didn't know that" with your cat,
we're here for some discerning learning.
it's some Gravity CPD. And so to our first pearl and contraception, weight and GLP-1s. And this one took me 12 minutes and 22 seconds. And Fee, 7 minutes 55. What's going on there, Fiona? Anyway, so Fee and I are joined by Hussein for this one. So hi, Hussein, how are you doing?
I'm very well, thank you.
Excellent. What have you been up to recently?
I've been getting out. I had a clavicle fracture a few weeks ago, so it's been great to have my arm back. So I've been making the most of that and enjoying having two arms.
Oh, bless you. I'm glad that you're getting back to normal. So let's get started. And weight is an important factor as well as a medical issue when it comes to choosing contraception. Our patients might worry about the impact of contraception on their weight, and misconceptions may deter patients from using effective methods. And also, they might stop their contraception due to coincidental weight gain.
And as healthcare professionals, we should consider the impact of weight on a patient's risk of adverse medical events with certain contraceptive methods. Also, the importance of effective contraception for those living with obesity or underweight to prevent an unplanned pregnancy with increased risk of complications. And also, we should consider counselling about the different methods of contraception and the importance of maintaining a healthy weight. The Faculty of Sexual and Reproductive Healthcare, or FSRH, has published numerous guidance documents regarding weight and contraception, including contraceptive options for women with eating disorders. The main points of these guidelines are summarised in the Written Pearl, an associated article on Redwell Knowledge, which was updated in June this year.
Now, when it comes to weight gain and contraception, this is something that we often get asked about in primary care. And in our discussions, we should consider that weight gain is rarely a primary outcome in contraception studies. And there's a lack of consensus on what constitutes excessive or, in inverted commas, unacceptable weight gain. And weight gain can be a normal characteristic of growing older, especially in adolescence. And we should also consider that there may be other lifestyle and confounding factors. And of course, all of this makes it difficult to determine the exact relationship between hormonal contraception and weight gain.
Hussein, what do we have to consider when prescribing contraceptives for those living with being overweight or obesity?
There's actually limited safety data regarding contraceptive use in obesity, particularly if BMI 40 or over, or when combined with other comorbidities. So we do need to keep that in the back of our minds. However, we do know that those living with obesity are already at increased risk of cardiovascular disease and cancer, in particular endometrial and breast. So caution may be needed. The baseline risk of VTE in those living with obesity is twofold higher than in women whose weight is in the healthy range. We're often talking about risk benefits in primary care, and there is no difference here. If we start with the risks, the combined hormonal contraceptive increases the risk of cardiovascular disease, VTE, and breast and cervical cancer. Progesterone-only methods, including intrauterine systems, implants, pills, and injections, may also increase the risk of breast cancer slightly. A small amount of observational data has found an increased rate of VTE amongst progesterone-only injectable users, which is interesting, but more research is needed before a causal association can be confirmed. Let's move on to the benefits. Now, the combined hormonal contraceptive reduces the risk of endometrial, ovarian, and colorectal cancer. The levonorgestrel-releasing intrauterine system, or LNG-RUS, if you don't have to say that every time, is associated with a reduced risk of endometrial cancer. A BJGP umbrella review in 2025, including systematic reviews and meta-analyses, found that ever use of any IUS was associated with reduced risk of endometrial cancer, as well as cervical and ovarian. It also found 2 studies suggesting a possible but not statistically significant increased risk of breast cancer. Limited evidence indicates no association between non-IUS progesterone-only contraception and endometrial or ovarian cancer.
What about the relationship between the different methods of contraception and weight, Fee?
So we have a handy table in the Pearl that gives all this information, which is quite a relief, really. It highlights the UK MEC for each contraceptive method, and that helps us as clinicians to decide what contraceptives they can safely recommend based on the medical conditions of patients in their care. So as a reminder, it's graded 1 to 4. UK MEC 1 is no restriction to use. 2 is that the benefits usually outweigh the risks. 3 is that risks usually outweigh the benefits, so it's a relative contraindication there. And 4, well, that's an absolute contraindication. And interestingly, because we're talking about obesity here, obesity is not a UK MEC 4 for any method of contraception. So it's worth keeping that in mind. We've got 5 classes of contraception included here. So first up are the long-acting reversible contraceptives, or LARCs. So that includes intrauterine contraception, subdermal implant, and progesterone-only injectable, or the depot injection. And then we've got the non-LARCs, so the progesterone-only pill, and then the combined hormonal contraceptions, which include pills and patches. So Nick, could you tell us about the LARCs, please?
Sure. So looking at intrauterine contraception, this does not cause weight gain and is a highly effective contraception in women of all BMIs. Overweight or obesity does not impair this method of contraception. UK MEC with obesity, so that's a BMI of 30 or more, is 1, but UK MEC 2 for IUS, the progesterone-containing intrauterine system, if they are obese and they have any other risk factor for CVD, so smoking, hypertension, diabetes, or dyslipidemias. Now, the subdermal implant does not cause weight gain either, and being overweight or obese does not impair this method of contraception. Just like IUCs, the UK MEC with obesity is 1, but UK MEC 2 if obese and they have another risk factor for CVD. And the final LARCs, the progesterone-only injectable or depot injection, now this is different as this may be associated with weight gain, especially in adolescents with a high BMI. There's no evidence of reduction in efficacy in overweight or obesity, although data is limited if BMI is more than 40. In obese women, the FSRH recommends some considerations: a longer needle or deltoid injection to ensure intramuscular placement of the Depo-Provera, also consideration of subcutaneous formulation. The UK MEC with obesity is 1, but UK MEC 3 if obese and has another risk factor for CVD.
Okay, great. Thanks, Nick. Hussein, what's the advice on the non-LARC contraception then?
Progesterone-only pill first. This does not cause weight gain. Being overweight or obese does not impair this method of contraception, so we do not need to increase the dose in obesity. Like the IUC and subdermal implant, the UK MEC with obesity for the progesterone-only pill is 1, with a UK MEC of 2 if obese and has another risk factor of cardiovascular disease.
And finally, combined hormonal contraception, or CHC.
So combined hormonal contraception does not cause weight gain either. Being overweight or obese does not impair this method of contraception in most cases, but with one important exception. The efficacy of the combined patch may be reduced in women who have a body weight of over 90 kilos, so we should avoid it. It's definitely worth remembering and certainly was a learning point for me. And when we're thinking about combined hormonal contraception, the UK MEC with obesity is less favourable. So it's UK MEC 2 if the BMI is 30 or more and up to, but not including 35. It moves on to UK MEC 3 if that person has another risk factor for cardiovascular disease. And we've seen that theme coming through, haven't we, in the other contraceptives. And then it moves also to UK MEC 3 if the BMI is 35 or over. But also, just to reiterate what I said earlier, in UK MEC terms, 4 is absolute contraindication and obesity is not a UK MEC 4 for any method of contraception.
And what about weight considerations around emergency contraception, Fee?
Yeah, so this is a good nugget to remember. It's also in the article, so you can look this up when you need to. The copper IUD is the most effective emergency contraceptive method and is unaffected by weight. Now, we should offer this first line to anyone anyway, but of course, we know that access to fitting may be a barrier here. The efficacy of oral emergency contraception may be reduced by being overweight, particularly levonorgestrel 1.5 milligrams. Therefore, in those with a BMI of over 26, which is not necessarily a BMI that would catch your attention unless you were thinking about it, in those people who request oral emergency contraception, we should offer ulipristal acetate 30 milligrams, which goes under the brand of Ella1 as first line. And if that's not suitable, then we should offer 3 milligrams, which is a double dose of levonorgestrel.
Now, you've been telling Kat and Ben all about this on This Morning, and indeed Dermot and Alison Hussein. So it was about time when we got you in and we offered you a coffee and got you to tell us all about contraception, pregnancy and weight management treatments.
Where's my coffee then, Nick?
It's a virtual one.
Oh, you seem right through us, isn't it?
Virtual coffee.
It's always good to come and chat to my Red Whale family. Oh. So let's start with weight loss medication. And as Nick said during the bubbles at the top of the episode, in June 2025, the MHRA released an alert which contained their guidance on planning pregnancy for women using GLP-1 agonists. They told us that GLP-1 medication should be avoided during pregnancy due to lack of safety data. The MHRA recommends a washout period after stopping these medications before trying to conceive. Now, this washout period is different depending on which one. So with semaglutide, you should stop at least 2 months before pregnancy. For tirzepatide, stop at least 1 month before pregnancy. And for liraglutide, there's actually no washout period required. It's also important to say that some weight loss medications may reduce the efficacy of hormonal contraception. Now, Orlistat, which we've been using for a number of years, given its impacts in potentially causing vomiting and diarrhea, when we're using oral methods like the combined oral contraceptive or the progesterone-only pill, we need to follow missed pill rules. And this is if vomiting occurs within 3 hours of taking the pill, or severe diarrhea occurs for more than 24 hours. Now, if there is persistent diarrhea or vomiting, consider non-oral method and recommend consistent use of condoms. Now, for our GLP-1 agonists, really we sort of focus our attention on tirzepatide, which is a GLP-1 and a GIP, so it's a dual receptor agent. And here, for both the combined hormonal contraceptive options and the progesterone-only pill, there is advice when we're thinking about our patients that are starting or increasing their dose, and that lasts for 4 weeks. So when you're either starting tirzepatide or there's been a dose increase, then women should be advised to use a non-oral method. So they should either be using additional barrier contraception or a non-oral method in that time. After the 4 weeks, they can then resume back on their previous contraception if that's what they would prefer. And when it comes to considering how we communicate to the patients, we need to firstly know whether our patients are taking these injections, because bear in mind, many of them may be accessing it privately and you may not be initially aware. So another reason when doing these kind of checks to ask in the first place.
Thanks, Hussein. I think that's really helpful. And when I saw this update, I was thinking about sort of putting this into action and the practical things that we need to think of, you know, when our patients are in front of us. Now, we've got lots of patients taking tirzepatide privately. And so like you were just saying, I wonder if this should be something that, you know, either we ask at contraceptive reviews or maybe putting into, you know, our SMS template so that people can highlight us of this, because otherwise, you know, how would we know?
Absolutely, yeah. Like if we don't ask, then often the patients will not volunteer that information.
Yeah, so maybe that's a sort of a bit of a take action point to think about in our practices, how we do that. And then the other thing was just around the alternative contraceptions when we're thinking about starting and the dose changes. Because when I read this, I thought, well, actually, should we, you know, is it just better to be suggesting that people use barrier contraception for that kind of starting and titration period? I mean, is that essentially what the guidance is saying? Because I can't imagine trying to count 4 weeks and then think, oh, right, now I can go back to my contraception and back again. And obviously that's a high risk way to do things, isn't it, in terms of contraception? What do you think around that?
Yeah, it's the practicalities, because the guidance doesn't give advice as to how to practically implement it. Because you're right, when we're starting, let's say, tirzepatide, you'll be starting on 2.5 milligrams, and the dose range goes all the way up to 15. And you're advised that every 4 weeks they are reviewed and a decision made as to whether dose needs to increase. So it could be that it's far longer than 4 weeks that this applies, because although they've started on it, they're then going to have dose increases, which keeps extending the 4 weeks. So in reality, it may be a more practical option for both ourselves and the patient to look at a more longer term solution rather than a stopgap option. Of course, patient preference is going to guide this as to how they want to do it. But I think we should have on the back of our minds that it's highly unlikely that it's going to be a simple 4 weeks and then it stays there, because they're going to find a maintenance dose likely higher than 2.5.
Yeah. And then, so then it's thinking, well, actually, should we sort of be thinking, right, let's suggest those non-oral routes. Now, we know that, you know, good practice is to offer LARCs, isn't it? Because they're much more reliable and, you know, for patients, like you say, where it suits. So thinking about that. But of course, we need to just remember that, you know, patches are included in that non-oral recommendation, but we do need to avoid that in women who have a weight of greater than 90 kilograms, as we said earlier. So just kind of understanding all those nuances and options. But Thank
and
you.
in reality, at that weight, obviously it varies depending on what that BMI result will be. But at that weight, it's highly likely that everyone currently eligible through NHS treatment, of which is a small population, it means that the patch isn't going to be suitable for them. But those accessing it privately, remember, BMIs can be as low as 27 if they have a weight-related comorbidity to meet the MHRA licensing. So it is an important bit to be mindful of.
Brilliant. Thank you.
So that's the medication side of things. Now, on to weight loss surgery. If we start with bariatric surgery and fertility, those living with obesity are increased risk of infertility. Undergoing bariatric surgery improves fertility, as well as maternal outcomes. Now, due to accelerated weight loss and changes in digestive physiology post-surgery, women should avoid pregnancy for 12 to 18 months.
Now, we've been talking about contraception, Hussein. How does bariatric surgery affect contraception?
Well, there's little evidence examining the efficacy of different contraceptive methods in women who have undergone bariatric procedures. Oral contraception may be less effective post-operatively, so non-oral contraception should be considered. And finally, all those using combined hormonal contraception should stop at least 4 weeks prior to major surgery.
Contraception, weight and GLP-1s is a really hot topic right now and a rapidly changing area. So with that in mind, you might want to pre-order our brand new Obesity Medicine, Weight Management, GLP-1s and Beyond course right now. It's launching on Friday the 26th of September 2025, so not long now. Hussein, what can we expect when we come on the course? I have it in my diary to come along too.
Yeah, I'm really excited. It's been a real kind of labour of love. And I think what's great about this particular course is we've pulled together insights, experience and knowledge from a whole host of different places. So yes, we've got incredible input from a number of the team here at Redwell, including Lee, our mental health lead, covering the really important aspects there, as well as our cancer clinician, Jackie. And we've brought in people from behaviour change, whether it be health coaches, as well as patient. Getting their insights and their perspective. We sit down and spend 20 minutes exploring what it's like, what that experience is, because often I don't think we get that perspective. And I think with the course, yes, it looks at these new agents, which are very much transforming healthcare as we know it. But it looks beyond that to try to understand stigma as well as the social determinants and some of the key drivers in our environment that are influencing obesity. So I'm hoping it will be a real solid foundation to support clinicians to work in an area where, if we're being honest, we're going to see this expand massively over the next 15, 20 years, where obesity medicine is coming into primary care.
Excellent. Thank you, Hussein. And Obesity Medicine, Weight Management, GLP-1s and Beyond, as Fiona said, launches on Friday, the 26th of September, 2025. So you can sign up for that now. And I believe you're coming back next month, aren't you? I think we're talking about obesity and weight management in pregnancy. Is that right?
Absolutely. And yes, it's quite interesting. A lot of learning points there.
Fabulous. So we look forward to that.
And I'll be expecting a real coffee this time.
We'll sort that out for you.
Can we send that to you?
Absolutely. In the post.
I
don't mind warming it up.
I was going to say it might not be hot, Hussein.
That's fine.
So here are our learning points for contraception, weight and GLP-1s. There's no evidence that obesity affects the efficacy of any method of contraception except the combined patch in women over 90 kilograms.
Obesity alone does not restrict the use of any method of contraception, but more caution is required with combined hormonal contraception.
In June 2025, the MHRA told us that GLP-1 medication should be avoided during pregnancy due to a lack of safety data. They also recommended a washout period after stopping these medications before trying to conceive. Semaglutide, stop at least 2 months before pregnancy. Tirzepatide, stop at least 1 month before pregnancy. And with liraglutide, no washout period is required.
An interesting and helpful one to start the month off with, and we need to remember to get Hussein a coffee for next time, don't we? So, anyway, how are you doing, Fee? What's going on?
I think the last time I joined you on the podcast, Nick, I was coming down with something, so I'm feeling much better.
Good.
You'll be pleased to know, you can probably hear in my voice. I'm really happy because a couple of weeks ago, I fell over while running,
Oh.
a bit tragically. I'm not happy because of that, but I'm happy because I'm getting better and I'm back to doing a bit of activity this week, which is one of those things you kind of don't realise you've missed it so much. And then when you can actually do something, you suddenly become a much nicer person to be around.
Oh.
I find.
Yeah, you're always nice to be around, but
Oh,
but
thanks.
I've noticed, because I've been managing to do. I started this when I was on holiday, which was really cool. Some HIIT classes.
Oh, yeah.
And I was doing the lovely Joe Wicks class, which I dug out from when I was in lockdown, and then I've also found that it's on my. I'm subscribed to one of these cycling thingamajigs, but they also have fit cardio classes as well, and I've been doing it 4 times a week. And I've been feeling much better, but also sort of mentally as well, in that, when there's been sort of stressful times at work, it's been really, really helpful. The one thing that I should confess to is that, and I've been so good about not having any sort of naughty snacks or anything, but there was one...
You shouldn't be saying naughty. That's the problem right there.
Okay. But I'd done a really busy day at work, and I was driving home, had to fill up with some petrol, and that was where it all went a bit wrong.
Yeah.
And
it's
my
best
inner
if you
chimp...
pay at pump, isn't it?
Oh, totally. And the inner chimp, well, that's so true. But my inner chimp took over, and I literally, there were biscuits, there was chocolate, there was all sorts of things that I haven't eaten for weeks. And then as I put them to pay for the fuel, the lady behind the till said, "You're a doctor, aren't you?" And I went, and when you just cut and you have, yeah, that's me, that's yes. And I'd seen her as a patient a while ago, and she remembered. And there was me mortified with snacks that were clearly for somebody else that I was buying.
Mortified. It's all in balance. Nick, I was on duty the other day, and I was finishing up, and I thought, do you know what? I think it's fish and chip night tonight.
Totally.
And honestly, I left my duty not feeling, stressed and grumpy like I normally do. I left it thinking, ooh, here's my reward for being on duty.
Brilliant. And it's
So I might put
always
that
good.
as life hack.
Reward after, duty rewards is good.
And it's all about balance, isn't it? It's all about balance. And we are humans. And it's difficult, isn't it? Because yes, you are a doctor, but at that point you were just a normal person who can have a treat.
Yes, exactly. Are you a GP trainee, or do you know one? We've got some exciting news.
We know that GP trainee years can feel daunting and expensive. So Redwell has joined forces with the MDU to provide a free education package tailored to GP trainees, which has been really popular. Nick, can you tell us about it?
Of course, this is the GP Trainee Essential Support Package, exclusively available to GP ST MDU members and affiliates. It's worth £165 and is designed to build your knowledge and confidence to help you pass your exams. So what does it include, Fee?
You get access to the whole of Redwell knowledge. That's over 900 written resources to support you during consultations and with exam preparation. Some of you describe it as like having an educational supervisor in your pocket. There's also a digital Top AKT Topics handbook, which contains topics that the RCGP says people find challenging in exams.
You also get access to 4 on-demand exam preparation webinars that demystify workplace-based assessment, AKT, SCA, as well as statistics and data interpretation.
And from August 2025, we'll be sharing a monthly video bite on common primary care presentations to support your learning even more.
So, who's eligible and how do they access it?
This all depends on where you are training. If you're a GP trainee in England, indemnity is provided through your deanery. But in addition to this, you can sign up for free MDU affiliate membership anytime during your training. You will then be able to access the GP Trainee Essential Support Package for free. And if you're a GP trainee in Scotland, Northern Ireland or Wales, you choose and pay for your own indemnity. Therefore, if you choose the MDU as your indemnity provider, then you will gain free access to the GP Trainee Essential Support Package. Just visit themdu.com to find out more. Click Choose to Join MDU and you can see all the options.
Once you're signed up, you'll receive a code from the MDU so that you can access GP Trainee Essentials as a free member benefit. And when you CCT, if you choose to continue with MDU indemnity, then you'll get a free Red Whale course of your choice or a discount on Red Whale Unlimited to support you in your first year of practice. So, if this is of interest to you, then see the link in the show notes for full information and T's and C's, or search Red Whale GP Trainee Essentials to learn more. Have you got the calendar there?
Yes. So what's coming up in the calendar? Well, we're going into our period of writing new teaching material. So it's a very exciting time here at Redwell. The authoring team are finalising up their new and updated articles. They've been working really, really hard. So big shout out to them. We've just had our editorial meeting to work out all the most useful and practice changing topics that we're going to teach and include over the next rest of the year, really. And we'll be filming all of that new content over the next couple of months. So it's an exciting time. Dates for your diaries and things to book on for. We've mentioned Hussein has got a live obesity course. So that's the first one, which is kicking off on Friday, the 26th of September. So do book your place onto that. We've got a menopause half-day course coming up 5th of September in the morning. So book your study leave and place. You can join Helen for that, but it's also on demand. So if you can't make this date, but you urgently need to get your menopause or HRT ducks in a row, then do pop that down. And we've also got our live GP update course on Saturday, the 27th of September. So lots going on, and hopefully far enough in advance to kind of get things sorted so that you can join us there. And if you're out and about over the next few weeks, then Hussein is doing a study day live for the East of England on the 19th of August. So if you're part of that, then do say hi to them, and remember to give our superhero nominations for the podcast.
Excellent. Thank you. So now we've got some fun and interesting topics this month. And here at Red Whale, we want to make your life as a clinician easier.
That's right. Topics that we discuss here might make tomorrow easier for you because you joined us here today. Things that are new or recently updated, or things that we all find tricky.
And things that you just might not hear about anywhere else. And if you want to hear about how we made one clinician's life easier after they listened to our last episode, then stay with us until the end of this episode, because we have a primary care superhero who tells us just that. So, Fee, are you ready for our second pearl?
I think so.
Excellent. So this one is that there is no safe level of drinking. Have we missed the message? Now, this one took me 24 minutes and 17 seconds to read, and it also took Fee 19 minutes and 10 seconds to read, so it's a bumper pearl. Now, even since we released the pearl, the article is being updated to include some great information about alcohol use in the context of health inequalities, and yes, believe it or not, the use of GLP-1s to reduce alcohol-related harm. So if this is an area of interest to you, then check back on Red Whale Knowledge soon for these great updates. But today we're going to focus on three areas: why alcohol and the messaging around it matters, including the potential harms, and we think this is often a glossed over risk factor. Audit, we often have a lot of this information in the patient record, and so are we actually using it? We're going to consider that. And then frames, did you know about it? Are you using it? So we're going to cover all those things. And so let's start with why it matters. So here's the background and some statistics for you. About 1/4 of the UK adult population drinks alcohol in a way that is potentially or actually harmful, but few of them access treatment. And that's huge. Now, The Lancet in 2018 published some facts, and they told us that hospital admissions with a primary alcohol-related diagnosis have increased by 17% between 2006-7 and 2016-17. 31% of men and 16% of women drink more than the recommended weekly limit of alcohol. And between 2013-14 and 2017-18, funding for addiction services has been cut by 18%. Now, of course, all of these statistics may be different now in 2025, but the BMJ in 2025 told us that deaths from alcohol-related causes have increased by 60% from before the pandemic. So, Fee, why do you think this is a difficult area for us in the UK?
I'm really shocked by, that most recent stat there from the BMJ as well, because I suppose, a lot of us are exposed to what our peer groups do, but not necessarily what other groups do. And as we'll go into discuss, the behaviours are different in different age groups and maybe different cultures and things like that. And I know certainly for, the sort of culture that I've been brought up in, use alcohol to celebrate. You might use it to commiserate. It can be ingrained in daily life without thinking of it as a risk factor or, risky behaviour. But that makes it difficult then for maybe people to come forward and get support or seek support for others.
Yeah, and I think it's also difficult for people that don't drink. I mean, I didn't start drinking till I was in my 20s, and the reason why I started drinking was because I was so bored in a social situation with people just saying to me, "Why don't you drink?" And sometimes, and back then there weren't very many sort of non-alcoholic drinks, so I would stand there with an alcoholic drink just because then people wouldn't ask me, but then they'd go, "Oh, why are you drinking?" And it's like, "Oh my goodness, you just can't win." So hopefully things have moved on now, and it is more acceptable not to drink alcohol because there's so many alternatives, which is wonderful.
We're seeing younger people choosing just not to drink.
Exactly,
and that's acceptable within their peer group.
Yeah, exactly. And I think, sometimes when somebody has realised that there's something going on and they want to make a change, then the first step is being more aware of exactly how much they're drinking.
Yeah, exactly. So the guidelines from the UK Chief Medical Officer, based on a review of all the evidence published since 1995, were updated in 2016. And the key message from 2016 is that there is no safe level of drinking. But, we're now in 2025, so has there been a missed message here? The risk of developing a range of illnesses increases with any amount of alcohol consumed, and that should be a message that we're imparting. And guidance is now the same for men and women, and that's up to 14 units per week. It's best to spread this evenly over 3 days or more, because having 1 or 2 heavy drinking sessions increases the risk of death from long-term illnesses, accidents, and of course injuries. And a good piece of advice is that a good way to cut down on alcohol is to have several drink-free days each week.
And how do we go about measuring alcohol consumption fee?
Yeah, it's important that it's accurate, isn't it? Because knowing that helps us to work out what we need to do. But it is a hard one to get right, and in my experience, everyone tends to underestimate it. Looking it up is definitely the best way to get an accurate calculation, and do have a look in our article for this.
Yes, and in fact, I remember one of the team from our local alcohol service where I'm based came to talk to us one Friday morning, and they brought with them these measuring cups that you can get, which you can basically, if you pour your drink into it, and it tells you from the little sort of gauge on the side how many units are in that particular drink. So that's a really good way of, if you want to keep a diary of exactly how much you're having in a week, then that's a really good way of doing that.
I think what's difficult though is, we were just chatting as colleagues here at Redwell, and talking about, as the kind of cost of eating out and drinking out goes up and up, people may be drinking more at home. And sometimes it's harder to keep tabs on what you're drinking because you're not buying a large glass of wine or a pint of beer. And so it's difficult for us as clinicians to help people if they're not entirely sure what they're consuming as well. So, it's a tricky one.
It certainly is. So how do we go about identifying alcohol use disorders, Fee?
So this isn't a new area. NICE published guidance back in 2010 entitled Alcohol Use Disorders Prevention. And NICE recommends that we should carry out alcohol screening as part of routine practice, identifying drinkers at increased risk of harm, and provide brief advice. To improve detection, we should screen groups which are potentially at risk, including those with related physical conditions, so things that you'd expect, things like GI or liver disorders, but also, hypertension. And I'm not sure we're all doing that all the time. Thinking about mental health problems, so people with anxiety or depression, people who've a history of being assaulted, people who regularly have unintentional injuries or minor trauma. And I was thinking about that and thinking, well, I don't know if we'd necessarily flag that up, especially if our patients might be going to A&E or minor injuries units. Would we pick up that trail? People who regularly attend gum clinics, again, might be hard for us in primary care to do that. And also this last one, which might be a surprise for some and really made me think, was people who have repeat requests for emergency contraception. And I thought, well, again, that could be hard because they could be asking us, but they could be going to the pharmacist, and they could also be going to the gum clinic. So thinking about those, and if you come across someone, then actually just remembering this and thinking to ask about alcohol.
And it's also really tricky as well because there's so much shame involved in this. So even if you are somebody that maybe has had a minor trauma or something like that, or emergency contraception, their knee-jerk reaction, if you ask them about alcohol, we say, no, it wasn't alcohol related. And so sometimes this might come out later on in a consultation or down the line.
Yeah, and I think it's that really important point of, offering support in that non-judgment way, they may run for the hills, but they know that you're then a safe person. They can come back to you. Then always offering for them to come back to you. Yeah, it's a really good point, Nick. The other thing that I thought was a really interesting learning point was around older adults. So since the publication of the NICE guideline back in 2010, there's emerging concern about alcohol use disorder in older adults. And this came from the BMJ this year in 2025. So if we go back to 2012, people aged over 65 made up 12% of heavy drinkers, and that's defined as more than 50 units per week for men and more than 35 units per week for women. In 2022, this had nearly doubled to 21%. Wow. Isn't that interesting? And they also make the point that older people are underrepresented in alcohol treatment pathways and are at higher risk of alcohol-related harm due to accidents and other comorbidities. And a BMJ analysis called for a national approach targeting drinking in older people and for primary care clinicians like us to be aware of higher risks in this age group. And I thought that's definitely one for the learning points and maybe an action plan, an action point to go and discuss that with your colleagues, because I imagine that's an area that maybe we're not all aware of.
Absolutely. I guess we're already aware that services for alcohol are not targeted at older people. And it's not just about the tone, but it's also about being able to help people who maybe have got hearing problems and all that kind of
accessibility
stuff as well. Exactly.
Yeah,
definitely.
Yeah, and maybe even IT literacy. If they're not able to refer themselves using a smartphone or an internet browser or something, then it's thinking around all of that.
And particularly because funding's been cut recently as well, then I suspect that this isn't going to change anytime soon, which is really sad.
Yeah, absolutely. You might be wondering, where do blood tests come into this? And blood tests such as, liver function tests or LFTs, they're not normally used to screen for alcohol use disorders. But an incidental finding of abnormal LFTs should prompt assessment for alcohol use. And don't be reassured by normal LFTs in those drinking at increasing levels of risk, though. That's a really important point to say. If you're a Redwell Unlimited member or Redwell Knowledge member, then you may find the GEMS on liver disease on Redwell Knowledge of interest. And certainly, I think the ALT GEMS is one of those that is permanently bookmarked on my account because it's really helpful. And of course, when we think about investigating abnormal LFTs, asking about alcohol is one of the foundations, isn't it?
Absolutely. And yeah, my GEMS for the liver disease is always open because, when you've got so many blood results to go through and you're always getting stuff like that, it's so important to be able to have somewhere to start and to be able to sort of find your way through, isn't it?
Yeah, exactly. So we're talking about it being, a big issue and still a big issue and maybe becoming more of an issue. But where do we stand on screening, Nick?
Okay, so the WHO Alcohol Use Disorder Identification Tool, or audit, that I'm sure most of us have heard about, is considered the most accurate questionnaire for assessing the risk of a person's alcohol consumption. However, it does take time to complete, so the shorter pre-screening questionnaire, Audit C, can be used to identify people who may be drinking alcohol at hazardous or harmful levels. Now, Audit C uses the first 3 questions from the full audit tool, and the questions are: how often do you have a drink containing alcohol? How many units of alcohol do you drink on a typical day when you're drinking? And how often have you had 6 or more units if you're female or 8 or more if you're male on a single occasion in the last year? Now, a score of 5 or more is a positive screen, or if you're under 18 or over 65, then it's 3 or more. And so you can see that there's a lower threshold there for younger and older groups. So were you aware of that, Fee?
I wasn't, if I'm honest. I think audit's one of those things that, sort of gets done when we get new patients joining. I'm not really too familiar with it, if I'm being really honest there. Yeah, but it does show that obviously that's a risk. Those kind of extremes of age, I suppose. The ends, top and bottom ends of age. They're high risk groups.
Yeah, and I also guess it shows that we should also be asking people who are under the age of 18 if they are drinking alcohol, because often we're thinking, it's not legal to do that, so they won't be doing that. But of course, lots of people will be doing that as well. So a positive result then. This should prompt the completion of the full audit questionnaire. And then if I just quickly run through what we do with the full audit score. So between 0 and 7, then the risk level is deemed low risk. And the action there would be to offer positive feedback and general health advice. No further action is needed unless there are other risk factors present. A score of 8 to 15 is considered hazardous drinking, and we should offer brief intervention within primary care at that point. If it's 16 to 19 as the full audit score, then that's harmful high-risk drinking, and we should offer an extended brief intervention. If it's ineffective, then we should consider referral for further support. And a score of 20 or more would be possible dependency, and we shouldn't rely on brief advice here. We should refer to specialist alcohol services for assessment and consideration of medically assisted withdrawal. Now, because audit is often done as part of a new patient check, we often have a lot of this information in the patient records already, but it's all very well being there. Are we actually using it? What do you think, Fee?
Yeah, it's interesting, isn't it? Because I think sort of discussing between the team here at Redwell, there's varying practices on what we do in our places of work and within our teams. And, you'd want to be sure that if these, audit C is being filled out, that then that is prompting the full audit questionnaire, and then the patient's being seen by the clinician to do those things that you've just discussed, Nick. So, I wonder if this is an area for people to maybe go away and have a look, and maybe a really nice kind of quality improvement project or something.
Yeah, exactly. So an action point could be to check, is there a pathway in place at your practice to sort this out? And, trainees could get involved in this as well. And also the wider team, because we're all part of a large primary care team, range of roles involved, and they can also help with the brief intervention side of things as well. So more on the brief intervention in a moment. But for example, in our teams, we've got health coaches, we've got social prescribers, we've got nurses as well, pharmacists doing long-term condition reviews. All of the team could be involved in this.
Especially if we're thinking about that older people group that we mentioned earlier. It's about having those contacts, isn't it? And that every contact counts.
Exactly. And of course, the entire team can sign up for our pearls. They are free. So spread the word. And as always, there's a link to sign up in the show notes. So we were talking about under 18s, Fee. What about screening in them?
Yeah, it's a really good question. It's not one I'd really thought about until we were preparing for this episode. So NICE says that we can use audit in children as young as 10 years old. It says the threshold for referral and intervention should be lowered when we compare that with adults, but it doesn't give specifics. If we go over the pond and see what the Americans are doing, the American National Institute on Alcohol Abuse and Alcoholism Youth Screening Tool, gosh, that's a catchy name, isn't it? Is an alternative screening option in children. That was published by JAMA in 2024. And it can be used in patients aged 9 to 18 years. And questions here are age specific, which I think is important, isn't it? And the risk is determined by levels of drinking, both for the child and their friends. So it takes into account that peer group. And the tool also gives a guide for providing brief intervention. And there is a link at the end of the article. And I think, Nick, you'll pop that in the show notes, won't you?
Yeah.
Specialist addiction services don't typically accept under 18s here in the UK. Referrals should usually be to CAMS, so the Child and Adolescent Mental Health Service. But of course, the really important thing we shouldn't forget about in children is safeguarding. So a safeguarding issue if children are using alcohol. So Nick, how do we go about identifying alcohol dependency?
Well, Fee, alcohol dependency is suggested by an audit score of 20 or more, but it can be present in people with lower scores. So we need to be careful, and we need to have our primary care super senses ready here. Now, the ICD-10 diagnostic criteria tell us that there needs to be a cluster of behavioural, cognitive and physiological features that develop after repeated use of alcohol. So have a look at the list in the associated article. So let's move on now, and we're going to talk next about brief interventions for reducing alcohol consumption. So what can you tell me about that, Fee?
So brief advice should be given to people identified as drinking alcohol at increasing risk levels. That makes sense. And this should take 10 minutes or less and be accompanied by self-help material, and follow-up may be offered. And studies show that it does work. So 1 in 8 people reduce their alcohol to low risk levels after brief advice. Compare this to 1 in 20 who quit after smoking cessation advice is given. E-Learning for Healthcare has useful modules on delivering brief advice, and there's a link at the end of the Pearl and in the show notes.
Now we're going to highlight an approach now called frames. So Fee, have you been using this?
So I have to say I've missed this framework, despite it being around for quite a while. I mean, the thing is, Nick, as I'm sure everyone joining us today will feel, I find it's the jeopardy of time that is my issue here. You don't often get the full consultation to talk about alcohol, and it's usually minus minutes in my experience.
Exactly. And time is definitely a barrier. And for most of us, I'm sure that's true. And here's a question. Is brief intervention about alcohol being implemented by GPs across the board? What do you think?
Well, the evidence suggests not often, which is reassuring for me.
Yeah, not surprised though.
Yeah, interesting. So a representative cross-sectional survey of more than 15,000 people aged 16 and over in England looked at whether GPs were giving brief advice to patients who smoked or drank alcohol excessively. And this is from the BJGP in 2016. And the results suggest that brief advice for excessive alcohol consumption is rarely being given by GPs, and patients are more likely to receive advice about stopping smoking than cutting down alcohol. So everyone, why do we think this is? Nick, what do you think? Why do you think that is?
Well, I think the bottom line is it's an easier question, isn't it, to ask somebody about smoking. Do you smoke or not? And if they do, then we can refer to a service straight away. And I think it's more common and more acceptable to do this. And it's, lots of people want to stop smoking, and society is moving in that direction, whereas I'm not sure that that's where society is going as far as alcohol is concerned. And with alcohol itself, both for the clinician and for the patient, they both need to identify that there's a problem. And often the patient might not admit to it, even if they think there is a problem.
Yeah. And I mean, sometimes people who smoke, you can smell it, can't you? Or you can see the tar staining on their fingers, that kind of thing. And it sort of feels like we're much further ahead with that. The other thing I was thinking about was the fact that in a lot of areas, alcohol and drug services are one. So actually there's all that stigma around, maybe finding that support, and we mentioned even accessibility of support for certain groups. The other thing is that quaff doesn't have alcohol in it, so there's not such a drive to do that. You haven't got that little pink box kind of shouting at you to give that advice and get on with things. And it's also more complex. So with smoking, it's often right. Do you want to quit? Okay, off we go. Let's refer you. Whereas with alcohol, the drive is usually around cutting down, and there's lots of other things involved in it. So can make it a harder, more time-consuming discussion.
Yes.
So let's talk about frames. So this is a suggested strategy for delivering that brief advice. So you ready?
I am.
Yeah, okay, right. So person is identified as having increased risk or higher risk drinking by the audit tool. And then what frames suggests is that we make a transitional statement. So something along the lines of, your questionnaire results show that you're drinking at an increased risk level. How do you feel about that? Or would you like to know about that? So in that kind of non-judgmental way, and offering that advice. And then we might assess their readiness to change their drinking behaviour. You might say, how important is it for you to change that? Or it might just be from their response, mightn't it? We will know if they're interested. And then we would offer that brief advice. And the 6 essential elements are summarised by the acronym frames. So let's go through that. So F is for feedback. And the most important thing is that we offer this in a personalised, non-judgmental way. So it could be saying something along the lines of your level of drinking compared with others. So 62.5% of the population in the UK drink at a low risk level. And you might also want to give some factual statements around the effects of drinking at those levels of risk. So thinking about increased risk of accidents, or things like depression, impotence, sleep disturbance, liver disease and cancer, and then asking them how they feel about that. And then also, I think it's around sort of tailoring it to that individual. And, this will depend on how well you know them as well. But thinking about, actually if they are someone who is struggling with sleep, or they're struggling with depression, then actually saying, well, cutting down alcohol may well improve your symptoms in those areas.
R as part of frames. So R is for responsibility. And what we need to do here is highlight that it's their responsibility to make changes. It's their decision, and we want to reinforce their autonomy and ownership, and we're there to support them.
A is for advice. So giving clear, authoritative advice on units and recommended limits, as we've discussed earlier. And we may want to offer suggestions that have helped other patients and use the idea of small changes to achieve those bigger goals. For example, cutting back by a couple of drinks per week can help with your energy, your sleep and your well-being.
M is for menu and options to support achieve their drinking goal. For example, alcohol-free days or switch to lower alcohol drinks, alternating non-alcoholic drinks with alcoholic drinks, and also encouraging problem solving and choice.
E is for empathy, so adopt an understanding approach and keep this non-judgmental.
And finally, S is for self-efficacy. And we should show optimism and encouragement for the changes that they intend to make. You might want to say something like, what's one small step that you'd feel confident trying over the next week or two? So, does that sound doable? Fee, what do you think? Have you been using this?
Well, despite saying I hadn't really heard of frames and it had passed me by, I think I have actually been doing some of it. But what I've realised is maybe I'm doing little bits of it.
Yes.
And I think, that might be fine sometimes to use parts of it in an opportunistic way so that you can sort of create that trusting partnership.
Exactly. And by knowing about it, then perhaps we can detect that they need empathy that day, or maybe some advice and motivation to change. And we can be realistic with our resources, including time, but also to use that time well. Now, you might find our article on motivating behaviour change on Redwell Knowledge useful here. And that's available to people who have a Redwell Knowledge membership or Redwell Unlimited. So here are your learning points for alcohol. Use the whole team to act on Audit C and share your learning with them. And that can be an action point too.
There is emerging concern about alcohol use disorder in older adults. So as primary care clinicians, how can we be aware of these higher risks in this age group?
And use frames as a tool and a structure to offer brief advice. Time now for some primary care superheroes.
So first up is Dr. Perihan Collier. She's a retired GP partner, mentor, appraiser and all-round fabulous person. Always so smiley and sees the potential and positives in everyone, all the best parts of general practice. And 0073 on the text says, I love your pods. It makes my commute easier and more enjoyable with the nuggets and the delivery of the information. Keep it up.
Oh, thank you for that. And Claire Burrows has texted in. Hi, Claire. And she says,
Claire.
Hi, Ali, Fiona and Nick. I enjoyed listening to your last episode whilst on holiday in Madeira. I diagnosed my husband's Achilles tendinopathy after listening too. So thank you. That's brilliant feedback. Thanks for that, Claire.
And if anyone else is going on holiday, then please do listen to us from your sun lounger.
Absolutely. Now, if you are hankering after a Redwell Knowledge subscription, then we're offering a 10% discount on Redwell Knowledge for our fabulous Redwell pod members. And so how do you become a member, I hear you ask? Well, if you're listening to us now, then you're part of our pod. And all you have to do is go to redwhale.co.uk, put Redwell Knowledge in your basket and enter the code RedwellPod. And that gives you your 10% off. And here's a small print. The discount code is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, RedwellPod.
And if you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It should only take a few seconds of your time and we would really appreciate it. If you can spare a little more time, then please leave us a nice review too. Because of the way that algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms to the side, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcast platform.
And you can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want to see something about the podcast, then please use the hashtag RedwellPod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-well.co.uk. Until next time, I'm Fiona Ritchie.
And I'm Nick Kendrew.
Remember to keep Redwell Knowledge open on your desktop at work so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Bye-bye.
Bye.